I'd like to thank the organizers for the invitation to speak with you all about an often overlooked problem for cancer patients and survivors, and particularly breast cancer patients, body image and sexual health. Here are my disclosures. Let's talk about body image and sexual health after cancer in general. These are two of the common and potentially burdensome issues among all cancer survivors. Somewhere between 40 and 95% of all survivors report distressing sexual side effects. More than 50% of young adults report problems in over 2 areas of sexual functioning. And then, although sexual problems are common in the general population, compared to healthy controls, survivors still have significantly more challenges. So this is something that we need to pay attention to for all of our survivors and that we can actually do things about, and we'll talk about that. What about in breast cancer? Body image and sexual health are clearly intertwined, especially in women with breast cancer. First, grooming and appearance are integral aspects of sexuality. Everybody knows that. And then breast cancer treatment causes substantial body and body image changes. Loss of breast tissue, scars, skin changes, lymphedema, and of course, the breast is also a sexual organ for many. There's pain, loss of sensation and mobility, hair loss, hormonal changes, which of course can affect sexuality in addition to aesthetic, and then finally, weight changes, which can compound all of these issues. Body image after breast cancer has been recognized since at least 1935 formally as a multidimensional picture an individual forms in her mind of her own body with associated characteristics, including expression of emotions, imitation, identification, beauty, and social aspects. 3 areas or characteristics of this complex concept of body image in women who have been treated for breast cancer, and they've been noted to be the affective, or feeling feminine or feeling attractive, behavioral, or cognition, and you can see the explanations. There's an extensive literature documenting body image after breast cancer, which predominantly focuses on the newly diagnosed coping with mastectomy and adjuvant treatments. But what has been shown is that body image dissatisfaction relates to decreased quality of life. Who's more likely to have body image issues and decreased quality of life? Well, the higher risk groups are younger patients, patients with higher BMI, they report more body image distress. And then breast conserving therapy patients, immediate reconstruction and autologous tissue-based reconstruction for patients who need a mastectomy report more favorable body image outcomes. For young survivors who are this high-risk group, somewhere between 50 to 75% report poor body image satisfaction. So this is a real issue for a lot of our patients, particularly our young patients. Longitudinal data also shows that the relationships between depression, sexual difficulties, and body image distress, and for some, marital difficulties. So these things can all be related, which kind of makes sense. And there are limited data from lower resource settings, but that which is available suggests that there are disparities, and the difficulties are of greater severity and more diffuse effects in people who come from other underserved or underrepresented minority groups or lower resource groups. So this is also an area that's not well studied, but might be a much bigger issue. So what are the data? Well, let's, in the interest of time, I'm not going to go through all of the long data that we have around body image after breast cancer, but I'll show you a few examples that I think are exemplary. And this includes the NSABP prevention trial, the P1 trial, now reported, 20 years ago, 25 years ago, actually, where they showed women who were being treated in the preventative setting were unhappy with the appearance of their body. And you can see the numbers, nearly 60% across the board. And here you can see the younger women at about 60%, The women 50 to 59, also in the 60-ish% range. And this is again without surgery. And then as women got older, a little less unhappy, but still pretty unhappy. And so this is something that's not a new phenomenon, and it's not necessarily related to breast cancer surgery only. That being said, our survivors seem to do worse on average. Here, fast forward, some recent data from our group led by Shoshana Rosenberg, one of my colleagues, where she looked at 826 eligible women in the Young Women's Breast Cancer Study who were all diagnosed with breast cancer at age 40 or younger. And as you can see here, about 250 had breast conserving surgery, 197 had had unilateral mastectomy, 375 of this cohort had had bilateral mastectomy, obviously an increasing trend in our younger women. And they were enrolled in more of a modern era between 2006 and 2016, and they were followed for 5 years for the analysis. And we used the CARES physical, body image, and sexual subscales. And on these scales, higher scores indicate worse outcomes. And what did we find? Well, physical subscale, people seemed to all be doing okay. When you ask, can you move your arm? How are you feeling? How well are you sleeping? No big difference. It's, it looks like the bilateral mastectomy in the blue could be a little worse. Again, higher scores indicate, but not much daylight between those curves. But what about body image? Here we see more of a splay. I'll tell you, this wasn't statistically significant, but you can kind of see visually that it looks like the people with the bilateral mastectomies are having a little harder time than the people who haven't had bilateral mastectomy. And then moving towards the sexual subscale, this was the group that did have the most statistically significant difference, where those with bilateral mastectomy seem to be doing much worse, even at 5 years. So things get a little better, as you can see, going out from 1 to 5 years, but those who had bilateral mastectomy have sustained and worse outcomes when it came to their sexual health, whereas those that had unilateral mastectomy and those that had breast conserving surgery and mostly radiation seem to be doing a little better. And I'll note that most people in this cohort did have immediate or soon to be had reconstruction. Well, let's get into the granularity of that a little bit. Here you can see more details, body image by surgery. And I highlight that the bilateral mastectomy with no reconstruction group did the most poorly. And that's true in year 1 and year 5, but following up kind of closely behind them with the worst scores are the bilateral mastectomy with reconstruction group. And that's true when it comes to discomfort with body changes, embarrassment at showing the body, as well as discomfort showing scars to others. Well, what about other measures? This was the body image scale. What about sexual health in this cohort? Well, here we go. Once again, bilateral mastectomy without recon, the women seem to be doing the worst, certainly with perceived sexual unattractiveness, but bilateral mastectomy with reconstruction does seem to mitigate that to some degree, especially when compared to unilateral mastectomy with no recon or the bilateral mastectomy with recon. So it's not quite clear, and some women will get a bump from reconstruction for sure in their perceived sexual attractiveness. A disinterest in sex also was statistically significantly different across the groups. And you can see even at 1 in 5 years, if you look in that middle row, disinterest in sex was highest in those who had bilateral mastectomy without recon, but it was still pretty high and statistically greater in those who had recon but bilateral mastectomy. And the same was also true for decreased sexual activity frequency. So the women who had had more surgery seemed to be having a more difficult time, both from a body image standpoint and from a sexual functioning standpoint, even with reconstruction, which the majority of them had. Pretty important data as we inform this growing group of patients to how they make their choices. Well, what about psychosocial distress? Fortunately, depression was low across the board. You can see the women with HADS depression scores, the higher is the worse. And across the board, there doesn't appear to be any statistically significant difference depending on the surgery, but anxiety there was. And so the women who'd had bilateral mastectomy had higher anxiety both at 1 year, and while everybody seemed to get better, and they did seem to get a little better, they were still higher anxiety than the women who'd had less surgery. Now, that doesn't mean this is not a randomized trial, right? This is observational data. Women who choose to have bilateral mastectomy may be more anxious to begin with. And sometimes I do feel that my patients are treating their, peace of mind bilateral mastectomy decisions sometimes because the majority of these women did not have a BRCA1 or 2 or P53 mutation or some other high penetrance gene. But I do want to focus the fact that while they do feel a little better anxiety, it's not a panacea. So we can't use this to treat their anxiety and they still remain high. And we need to have other ways to help them with their anxiety, which is understandable for many. So what can we do to help them with their body image? Well, I think first and foremost, based on those young women's data and myriad other data prior to this, help women to choose surgery wisely. Make it not a rash decision based on anxiety, but based on the facts, their preferences, and their values and their risks. And then encourage reconstruction if a woman does choose to and or need to have a mastectomy, and make it available for that woman, because it's still far too many women don't have reconstruction for reasons that are not so clear, and there are disparities there. Advise and support women regarding the risk of weight gain. I showed you earlier that weight gain and inactivity through treatment, which is very common, is associated with worse body image. And we know that there are remedies to that: staying active, eating less, of course, or not eating too much during that time, and choosing better, making it a teachable moment to optimize diet and exercise through and beyond treatment. And with that, it's not only about advising women, but helping to plug them in with available programs, because we know it's hard. And then finally, all of this change is hard on the mind and the body. So behavioral therapy for patients can be quite helpful for issues around body image and many other issues around breast cancer treatment and survivorship. What else can we do? Well, I was excited as I was looking into this work that there is actually a randomized trial of an intervention that was developed in Australia called My Changed Body. And it's something that's not available for prime time yet. I looked really hard for it, but I hope it becomes available. It's online. It's a web-based psychological writing intervention, single session, where they randomized 149 women to the intervention versus an expressive writing control. We know expressive writing alone can help women, breast cancer survivors specifically, to manage distress. And that's been shown in other randomized trials. The women who were randomized to the My Changed Body single session focused on self-compassion and their body image had a statistically significant less body image distress and greater body appreciation and self-compassion on their follow-up. And these therapeutic effects were maintained at 1 and 3 months after the intervention, which is pretty striking. And if we can make that kind of dent for women, young women in particular, who are at higher risk, then this is something I think we should try and avail our patients of. And it doesn't seem to be like a high bang for buck. It seems like it would be worth it when something like this became available. So stay tuned. What about sexual health? Well, this is one of those things that people often are kind of like, it's a side gig and we don't need to worry about it too much because we got to treat the cancer. And, one of the things I like to normalize for patients and their partners is that, sexual health and sexual well-being, it's a life-affirming human experience across the lifespan. And to deny that is kind of to deny parts of people's humanity. And sex is a multidimensional experience. It's physical, it's psychological, it's interpersonal, and you always have to consider it in context for an individual and in her, microcosm. And this is a slide that I borrowed from my colleague Sharon Bober, which I think sets it up nicely, all the things that play into sexual health for a cancer survivor. And this is how we think about our patients in our sexual health clinic, which she leads, and again has lent me this in some of the other slides that follow. So what about sex, cancer, and quality of life? Well, the WHO has noted that satisfying sexual function is a health-related quality of life issue and a fundamental human right. And sexual dysfunction, we know, is associated with anxiety and depression, low self-esteem, and relationship distress. So this is something we should be paying attention to for our patients. Unlike other side effects, Sexual symptoms don't self-resolve. So it's not one of those things that just might get better on with time on its own, unless someone's like 18. And even then it might be hard. And untreated sexual dysfunction tends to worsen over time. And so this is something that you don't want to just kind of sweep under the rug. If you can attend to it, even as patients are early recovering from acute therapy or during, that's something we want to pay attention to. What are the common sexual problems for women? Well, there are disorders of sexual desire and sexual motivation. Those include hypoactive sexual desire, reduced sexual motivation, decreased body image, and loss of sexual self-esteem. And then there are disorders of sexual response, arousal, disorders of reduced lubrication, orgasm dysfunction, and chronic dyspareunia, which can, of course, compound all of the above. If a person's having a lot of pain with sex, most people are not going to enjoy that. What are the risk factors for sexual dysfunction? Well, a history of sexual problems, decreased relationship satisfaction if one is partnered before cancer, because things don't get typically better with cancer, absence of sexual activity returning to normal within 1 year post-treatment. So that's often a goal I try and set with patients when I ask them about this, try and get back to a close to normal so that, we're working from a baseline that they could work from. Poor physical functioning and functional impairment to start with or after the cancer, a history of depression and anxiety, and certainly if that's compounded by the cancer and the cancer treatment, then you have more digging out to do and you want to get that under control. And then finally, age and partner status. Young patients have more challenges, and those with partners often have more challenges, in part because many of them are trying to be sexually active. A lot of people aren't trying to be sexually active in this setting. And we know that there's a gap in care. The majority of survivors do not receive support for sexual problems. There was a recent study of young breast cancer survivors who'd been diagnosed between 20 and 35, women who are, someone in their prime and in theory should be sexually active beings. And greater than 6 months post-treatment, hopefully they'd be getting their groove back, feeling better, or all of the above. And 60% of women met criteria for sexual dysfunction. However, only 7% of the women who would have liked to have received education about cancer-related sexual problems during treatment received any support that they could recall. So this is an important gap in care, and this is something that we and our centers and our groups can do something about. Well, why aren't we doing it? Well, there are barriers. The culture is saturated with sex that we live in, but frank conversations about real sex are not encouraged. Clinicians feel unprepared. They don't receive enough training. They have limited time. There's also concerns sometimes about offending a patient or causing discomfort, or, how do you communicate about it? I know some of my male colleagues in particular don't want to seem overly interested in this because that can feel a little creepy to them and perhaps the patient. There are gender and cultural concerns, and of course, disparities. If a person's struggling with many other things, you might just not get to this. And then finally, clinicians aren't often sure what to say or do if a patient does have a problem, and it opens Pandora's box, can take up a lot of time in our already burdened healthcare system and in our clinics. So people tend to avoid that kind of thing. But what I want to say is we don't have to, because there are resources out there that don't need to take up all of our time. First of all, you do need to communicate. Communicate about sexual health is hampered by a perceived lack of available, brief, and effectual patient resources, but they exist. And once we communicate, identify, and assess symptoms, we can help people. So what can you use in your clinic to assess? Well, there are simple clinical checklists. There are education materials that one can have on hand. And then, of course, if you're in a center where you have a sexual health program like we do, you're lucky, you can send the person, or outside of your center to referrals and other resources, the gynecologist, the urologist, depending on the issue, a psychologist. This is an example of a questionnaire or a checklist. You can see this was published by Dr. Bober 4 years ago, and it's a really nice checklist. I highly recommend people look it up, and it's basically, how to ask and what to do, a guide for clinical inquiry and intervention for female sexual health after cancer. So here's how you might assess it in your practice. And there's what do you do when you find these things? And we'll talk about some of those, but couldn't be simpler. And it doesn't have to be the doctor. It doesn't even have to be the mid-level nurse practitioner or PA. It can be a program nurse. It can be a pamphlet that you screen with. Sometimes people are using patient-reported outcomes online. There are all these things, and people get the information and then they kind of ratchet it up if the information isn't good enough or patients have more questions. Or you could do a simple inquiry when you're seeing your patient. You can see listed here some suggested ways of saying it. Maybe many patients with cancer have questions about sexual functioning and how to treatment impacts sexuality. Do you have anything you'd like to ask? Can you tell me about the impact that cancer has had on your sexual functioning? Is there anything that's bothering you? And then finally, is a physical relationship with your partner an important part of your life? And has your current cancer treatment, survivorship, hormones significantly impacted this? Is there anything that you or your partner might want to ask about sexual functioning? No matter how you say it, and you have to find a way to say it where you're comfortable, or at least get the information to patients, ask the question or give them the info. It really is something that patients appreciate being asked about, and they'll tell you what they want to know once you open it up. And then again, you want to know where to send them. So how can we educate people? Well, if you're going to do it yourself, or you're going to send them to someone else, this is generally what they're going to talk about. Let's talk about vaginal health. First of all, moisture. As Sharon often says, the wetter, the better. Non-hormonal moisturizers are a mainstay for in-between sexual functioning, and then lubricants are a mainstay for during sexual functioning to avoid too much friction and irritation of the vaginal epithelium. Vaginal estrogens and other hormones, we all know that this is something we generally try to avoid in breast cancer survivors, particularly those with hormone-sensitive disease. That being said, sometimes we do reach for it when risks are not so high and our quality of life is significantly impaired. What about stretch? Pelvic floor work can be very helpful, dilation therapy and pelvic PT, and then of course, blood flow is related. Vibrator therapy can help with this. Self-touch, working with a partner in this. This is the use it or lose it section. It's definitely something you don't want to ignore. And the more vaginal penetration, the more blood flow to the vagina, but you got to be careful because of the concerns about dryness and about overstretching and or irritation. So it's something that, again, you want to counsel patients on, or have some materials to counsel them on, or send them to someone who focuses on this. What else do we have for our breast cancer survivors? Well, there are pharmacologic and other novel treatments. We talked about vaginal estrogen. Ideally, we know that it looks to be safe, but not long-term, large studies. So could you be missing some risk? Sure, but you got to weigh the pros and cons and the quality of life hit that a woman is facing. DHEA has shown some promise in terms of using it vaginally. That being said, again, not long-term outcomes, but generally thought to potentially be safe, although not clear. Lidocaine, some women will use. That being said, you losing all sensation and potentially losing it for the partner needs to be paid attention to, and the timing is critical there, is my understanding. Off-label vaginal testosterone, I think we'd worry about this in breast cancer survivors, pretty controversial. And then one of the latest things is the laser treatments. Right now, there are not great evidence for its utility after a breast cancer treatment, nor its long-term safety, but there are studies in the works, and it does seem to anecdotally and in small series work for some patients, but certainly not all. Finally, there are treatments for low desire medications, filbanserin, as well as bremelanotide, and that's something that hasn't been tested in breast cancer survivors. Not so clear that it would be not able to use in breast cancer survivors, but not so clear that it would actually work given the hormonal milieu of breast cancer survivors, especially if they're on hormones or have gone through an abrupt change. But that's something that's worthy of study and could potentially be used on a kind of person-by-person basis. What about behavioral interventions? Well, of course, there's a growing evidence base for behavioral interventions. Cognitive behavioral therapy, really important for anxiety in general, and can help with the sexual health and the body image issues. Mindfulness-based cognitive therapy or sexual therapy also has some nice data. Couples-based intimacy enhancement can be important, especially, it takes two to tango often, and psychoeducational interventions have been very helpful in some settings. Recently, there was another internet-based randomized controlled trial of cognitive behavioral therapy for breast cancer survivors with sexual dysfunction, and it led to improvement in overall sexual functioning, including desire, arousal, and vaginal lubrication. This was a 24-week therapist-guided session using a telephone platform. Successful, but resource intensive and time intensive. So Sharon and many of other colleagues around the country and the world are working on kind of shorter, 4 sessions to try and get patients both the psychotherapy aspects, the psychoeducational aspects, and more of the kind of nuts and bolts mechanic recommendations and the lubrication recommendations to do it in something that doesn't have to last 24 weeks and be this resource intensive. So stay tuned on those things. And then finally, I think communication, like in many aspects of cancer survivorship, are critical. Here, it's really about if a person is partnered, because that's where a lot of the stress happens. It's really about knowing what a partner needs and wants. And I love this cartoon. When I told him I'm not able to reach an orgasm, he said, try standing on a chair. So in conclusion, body image problems and sexual dysfunction are some of the most common enduring challenges after breast cancer. Attention to these important survivorship areas. Get a chest list, ask the patient in a non-threatening way. Awareness and communication with patients that symptoms can be improved is critical. And then when you find out they're having the symptoms, which 60% of patients might be, treat or know who you can refer to in your center. We have downloadable handouts that are available on the web. If you go to Dana-Farber information sheets for cancer survivors, if you Google that, you'll get our sexual health recommendations, and there's body image stuff in there. And you can refer people. You can go online, breastcancer.org. There are many other resources, and you probably have someone in your community who focuses on this too, to help your patients with these sensitive issues. And then finally, novel interventions are emerging online that may be even more accessible for patients, and more work will need to be done to make these useful, to get them disseminated, to make sure they're valuable and useful in diverse populations. But I'm highly optimistic about that. Thank you.